Oh,
I'll give people a little bit of time to join in.
okay, and then I will share my screen as well. And let me know when you want me to start, Dan.
Absolutely. So we'll give people a minute. Sarah Weber, looks like you have your hand up. Would you like to ask a question or give a comment?
Looks like she accidentally hit the raise hand button, so I think we're good.
Alrighty, so let's start this up. I'll introduce myself again for everyone that joined after my introduction before the meeting officially started. Good afternoon, everyone. My name is Dan Daniluk. I am a regional all hazards epidemiologist for the Oregon Health Authority. I work on the PSET team and the ACDP, which is the Preparedness Surge and Epidemiological team in the Acute and Communicable Disease Prevention Program. I specifically serve Marion, Polk, and Yamhill counties in our region, or in Western Oregon itself, I should say. Um, Actually, as well as Jackson-Josephine County too. Forgetting it stretches all the way down to the south. Yeah. So today I'll be facilitating this meeting too. Our topic for today is going to be presented by our MDRO epidemiologist, Therese Finn, who has a tremendous amount of experience in this and is very passionate about it. During our power hour, we'll be talking about MDR-focused enhanced barrier precautions. Alrighty, so Therese, do you want to start the slideshow?
Yes, thank you for the introduction, Dan. I am going to share my screen. I'm going to turn off my camera to make sure we don't have bandwidth problems, which sometimes I run into. And please give me a shout out that you can see the slides.
Wonderful, I can see the slides.
Okay, perfectly. So as Dan mentioned, I am the MDRO infection preventionist here in Western Oregon. I will mention that I'm actually not an epidemiologist. I'm a registered nurse. And I cover on this side of the Cascade Mountains from Washington down to California. So if you're in my area, I am your MDRO IP. I have my contact information here, and if you want to reach out. And we're going to start off by highlighting our learning opportunities today. So we're going to be having a little very brief presentation with Ryan Frick from ODHS, who's going to be sharing some information about an exciting collaborative on antimicrobial stewardship that we'll be launching. The bulk of my presentation will be focused on understanding MDROs, the burden of these MDROs, or multi-drug-resistant organisms, in our long-term care settings, ways that they spread to our residents, and also diving into the indications for using enhanced barrier precautions. So that being said, I'm going to hand it over to Ryan from Oregon Department of Human Services, and he's with the Office of Aging and People with Disabilities. So I'll let you go ahead, Ryan, and when you want me to advance the slide, just give me a shout out.
Great, thanks, Therese. You can probably advance it to the slide. I'll be very brief today. Hi, everybody. My name is Ryan Frick. As Therese said, I'm a population health epidemiologist with aging and people and disabilities at ODHS. You may have heard from me before in reference to some of our vaccination work, specific to long-term care facilities. You'll probably be hearing from me more on that topic as well as we move through 25. But today, I'm kind of excited to announce that we are launching a antibiotic stewardship educational collaborative learning series specific to long-term care facilities in the coming months here. You may have gotten a survey from me 2 weeks ago. I sent a reminder last week. I'm sending another reminder this week. That's kind of introducing this learning series that we'll be launching in March or April of this year. That really hopes to kind of just bring providers together and learn about antibiotic stewardship and kind of a really just kind of an informative kind of collaborative. This is kind of our first foray into this type of quality improvement and education type work from APD. So we're excited to have the support of HAI at OHA. So we are working together to kind of develop content, and that's really what we hope to accomplish with this survey. So the survey is linked here. I will also provide my contact information and a link to the survey in the chat, if that is okay with everyone. Should take no more than 5 minutes to complete, and we're really just hoping to get your insight about what you'd like to learn about, how you'd like to learn, the best way to kind of deliver those learning content modules, day of the week, kind of how you'd like to see that, what's best for our facility. So we've had kind of good participation. So if you're interested in this series, please feel free to participate in that survey. Again, it should take no more than 5 minutes. And then you'll be hearing from us, from me in the coming weeks around registration and then kind of how this series will work. We're planning on doing a monthly series for 6 months. That really kind of starts with an introduction to antibiotic stewardship and then kind of builds from there. We're hoping to have some guest speakers and kind of involvement from ODHS and HAI. So again, we're thankful for their support. So you'll be hearing more from me, and that's kind of how we hope to kind of launch this this type of collaborative. So we did a survey late in 2023. We found some kind of robust interest in delivering educational content in this type of way. So we're excited to launch this. And please let me know if you have any questions, and you'll be hearing from me with further details, I would say, in a couple weeks here, and we hope to launch soon. So thank you for your time, and please let me know if you have any questions. Thanks, Therese.
Thank you, Ryan. I believe that Mary's going to drop that link into the chat. I can't see it at the moment, but I'm going to trust that it's there.
Awesome,
And
yeah.
this is a great opportunity to dive into antimicrobial stewardship, which is so important in reducing the burden on multidrug-resistant organisms in our long-term care settings. So I hope you are as excited about it as we are here. I just as a housekeeping perspective, because of the way my brain works, I'd prefer not to have questions, but you can until the end of the presentation. I've tried to abbreviate this as much as I can to leave plenty of room for question and answers at the end. I am recording this session from the educational aspect of it, but once we open it up for question and answer, we'll go ahead and turn the recording off so everyone feels comfortable jumping on and asking questions either verbally or through the chat. And then Mary's going to keep an eye out on that for us as I walk through the presentation. So that being said, I'm going to dive in and start by just giving, a sort of an overview of where enhanced barrier precautions can be used. Centers for Disease Control, which is where enhanced barrier precautions came to us from, currently just provides recommendations for its use in the long-term care settings. I did want to make a note, though, that I have worked with some other non-long-term care facilities where enhanced barrier precautions has been of value, specifically in inpatient behavioral health settings where people have MDROs or open wounds, and also may have some value in rehab settings, inpatient rehab settings. So we'll start by talking about what MDROs are and why they matter. So MDRO is multidrug-resistant organism. And these are germs, mostly bacteria, but also can be fungi. And they essentially, an MDRO is an organism that's developed ways to protect itself from the medications that we use to treat infections with them. So most specifically, antibiotics, which is what Ryan was talking about, but also antifungals. These organisms, the MDROs, have an increased impact on individuals with underlying medical conditions, the very young, the elderly, those with immunocompromise, and living in congregate settings. So you can see where we're sort of selecting for a long-term care population with those features, right? And it's important to understand that when a resident has an infection with an MDRO, we really have fewer treatment options for them when they develop infection. So managing, controlling spread of these organisms is very important. And the scope of the problem is significant. The CDC estimates that there are more than 2.8 million MDRO infections per year in the United States, with a cost of more than $4.6 billion annually. So a significant impact of these organisms. For those of you who know me, I've followed MDROs for over 3 decades now. And when I first started in this role in about 30 or so years ago, it was really focused primarily on MRSA and VRE. But over the course of the decades, we've seen really an expansion of resistance developing. I call it the march of the alphabet because the letters just keep going on and on. So we started with MRSA, VRE, now we have ESBL, we have CRAB, we have CRE, we have CPOs, and this takeaway from this slide is the march is going on, and we will continue to have this challenge around antibiotic resistance and developing MDROs. I've had folks ask me, why are we doing a new type of precautions now? Well, there's a couple of perspectives on this. One is the impact of multi-drug resistance on residents of long-term care settings is pretty significant. One of the lessons that we learned with the isolation practices that we used during the COVID pandemic was the significant impact on the psychosocial well-being of residents with ongoing restrictive measures such as contact or isolation practices in long-term care. So enhanced barrier precautions is really a good compromise in some ways as a step above standard precautions, but being less restrictive than contact precautions for these residents. It is important to recognize that enhanced barrier precautions for long-term care is a CMS requirement, and a failure to implement enhanced barrier precautions can result in an F880 citation. So it is important to ensure that you're using the enhanced barrier precautions in your organization. So what is it about our long-term care resident population that makes them at particular risk for MDROs? So some of those factors are that oftentimes our residents have significant, serious underlying medical conditions like diabetes, heart disease, kidney disease. They tend to have long healthcare facility stays. They oftentimes have indwelling devices like urinary catheters or central lines, and they have frequent contact with healthcare workers. Additionally, they are exposed to more broad spectrum antibiotics and sometimes prolonged exposure. So that antibiotic use increases the pressure for developing these multi-drug resistant infections or organisms. I do want to encourage you to think about these MDROs in relation to our resident population in a couple of different boxes. And we use this image of this iceberg on the left-hand side because the majority of what we a minority of what we are aware of is above the water surface of the tip of the iceberg. And those are what we call our clinical cases. So clinical cases are when someone has an infection with one of these multi-drug resistant organisms, often causing symptoms. So fever, redness, swelling, pain. And because there are more organisms present causing infection, there can be an increased risk for spread. With these multi-drug resistant organisms, because they are more difficult to treat, we have a higher risk for poor outcomes. And a good example, resident outcomes when they get infected. And a good example of that, for instance, is with Candida auris, which I knock on wood, we haven't seen a lot of here in Oregon, fortunately, and we want to keep it that way. But the mortality rate for invasive Candida auris infections is that 1 in 3 residents or patients with these organisms do not survive that infection. So it's pretty impactful. And then the other aspect of this is what we call the below the surface, below the iceberg, is the colonized cases. And that's when these multi-drug resistant organisms live in or on a person's body. They're not causing infection. They're not causing any symptoms. And colonization can persist for long periods of time, particularly with certain types of MDROs. And depending on, that individual's conditions and healthcare circumstances, they can silently spread the organism to others in your organization, your facility. We also know that when they are carriers of MDROs or colonized, they can be at greater risk for developing an infection with those organisms. So I want to share a study that offers us a window into the burden of multi-drug resistant organisms in long-term care. And I find this particular study pretty fascinating. The title of it is High Prevalence of Multi-Drug Resistant Organism Colonization in 28 Nursing Homes, an Iceberg Effect. So again, we're looking at the bottom, what's below the surface and is unknown for colonized residents in long-term care. So this was a study that was done in between 2016 and 2017 involving 28 nursing homes in Southern California. And what they did in this study were they randomly sampled 50 residents in each nursing home. And 20 objects were also sampled in the resident rooms as well as in common areas. So during the course of this study, there were almost 2,800 swabs that were obtained. What was very interesting was they found that nearly half, 40% of the residents who were tested were colonized with one of any of the MDROs, so MRSA, VRE, ESBL, CRE, CPOs, etc. But what was particularly interesting was the top of the iceberg, which is that bit circled in red over on the right side of the graphic, only represented 4% of the patients who were previously known as colonized. So of that 48%, 44%, or the majority, their colonization with an MDRO was unknown. So this is pretty revealing to me as far as the burden of these organisms in our long-term care population. Additionally, it was identified that 74% of the rooms and 93% of common areas had identified contamination, which speaks to the impact of our environment in our skilled nursing facilities of colonization or contamination of these areas. So I'm going to take a moment and do a knowledge test. Now, for the knowledge test, I think Mary's going to be able to launch a poll for us. I'm not sure if I'm going to be able to see it, but Mary, please shout out if there are any problems with this. But you can either drop your answer into the chat or go ahead and respond to the poll. So the first polling question is, which of the following is not a rationale for using enhanced barrier precautions in long-term care settings? Number one, long-term care residents have a high burden of MDRO colonization. Number two, enhanced barrier precaution provides a way to reduce the risk for spread of MDRO without isolating a resident. Number three is residents of long-term care settings tend to be more vulnerable to infection with MDRO. Or number four, use of enhanced barrier precautions supports a reduced need for hand hygiene. So please drop your response into the chat or respond to the poll. And Mary, could you just kind of let me know what's happening with that, because I can't see it.
Yeah, so far we have about 36 responses.
Woohoo!
Let me know when you'd like me to close it.
Yeah, and could you tell us what the result was?
Yeah, so we have 38 responses now, and the all the responses are saying the use of EBP supports a reduced need for hand hygiene. So 100% saying that.
Woohoo! Well done, folks. Hand hygiene. We just must continue doing that. So good job. All right, I'll go ahead with the next slide. So this here I'm trying to provide you a visual for the human body and where germs live on and in us. So our body's exposed to millions of germs through our normal functions, like breathing and digestion. And oftentimes these are good germs and are referred to as our normal body flora. In fact, we have more germs in our body than we do cells. So, and these germs can live in our respiratory tract, they live on our skin, in our gut or GI tract, and also, viruses, HIV, hepatitis can live in our blood. So, anywhere where we have an opening or contact with the world around us, the skin, our mouth, our nose, our vagina, our rectum, it can normally be colonized with germs, and they can be good germs or multi-drug-resistant germs. So we are playing host to a wide variety of bacteria and organisms. One of my, I grew up in the Charlie Brown era, and this group of characters were some of my favorites. And in particular, I always loved Pigpen, and Pigpen is my visual for what happens in healthcare for me. Pigpen used to call himself, say of himself, I am a dust magnet. And my view of it is we're all dust magnets. And Charlie Brown's wisdom was, don't think of it as dust. Just think of it as the dirt and dust of far off lands blowing over here and settling on Pigpen. It staggers the imagination. And for me, the visual of this is that, we as individuals, as patients or our residents, they can go to far off lands, they can go to dialysis, they can go to inpatient healthcare, acute care settings for a while and be exposed to the dust and dirt of those far off lands. Or it can happen within our own facility and environment. But that image of Pigpen shedding around him as a cloud of dust helps to visualize what it is that's happening from us as seeding our environment. So that kind of brings us to the reservoirs. So our bodies are these reservoirs, either temporarily over a very long term of time, or over a long term of time. But we play host to these organisms, and sometimes they can become highly resistant disease-causing germs. So then we can colonize our respiratory tract, our skin, our gut, or GI tract with these organisms, and our residents as well, who then become a reservoir for providing these organisms to others in our long-term care setting. Additionally, we can have reservoirs from our environment. So the equipment that we use to provide care, surfaces and textiles that our residents are coming into contact with, toileting, showering, bathing areas can become contaminated. And also, you know, the water that comes into our building, it's not sterile. Sometimes there are gram-negative organisms that can live in and around those splash zones of our sinks. So, you know, the environment is another reservoir that we need to be considering in our long-term care facility milieu, basically. All right, so another knowledge test, and this question too is, residents of long-term care facilities are at increased risk for multi-drug-resistant colonization and infection. A recent California study identified which percentage of residents that were colonized with an MDRO. Option 1 is 5%. Option 2 is 25%. Option 3 is 48%. And option 4 is 74%. And I will let Mary monitor the responses and let me know what the results are.
All right, I have about 25 responses right now. We're seeing 56% voting 3, which is 48%. We have 22% saying 27% and 19% saying 74%.
Okay. And how many responses did we get altogether, Mary?
Right now we're at 32 responses. We're still weighing very heavily at 48% for the answer.
Okay. Great. Well, let's go ahead and close the poll, and we'll say that the right answer is 48%. So that study that we talked about was 44% of the people that were tested were unknown to be colonized, where only 4% were known, which gives us 48% colonization in that study. So thank you, everyone. Okay, so now we're going to talk about prevention. So we know we have reservoirs of MDROs in our facility. And here on the graphic on the right is what's commonly called the chain of transmission in healthcare. And it goes around the circle where we have a susceptible host. For us in skilled nursing or long-term care, it tends to be the elderly, and again, immunocompromised. And then there needs to be a pathogen, so a bacteria or a fungus. And there needs to be a reservoir where that germ lives, and how does it get out of the reservoir and then get spread to others, and then get to carried to others, and then is spread. So that's the chain of transmission. Everything that we do in regards to our infection prevention and control program is to find ways to break the chain of transmission. And that's the entire focus of what we're trying to do. So I like to think of an infection prevention program as 3 legs of a stool. And if all 3 legs of your infection control program are strong, it provides a pretty stable and balanced infection prevention program. And then if you throw things on top of it, like a diarrheal illness or highly resistant gram-negative organisms or COVID-19, which is at the top of that pile on the stool, you know, you might shake a little bit, but your program is going to stay solid. So the 3 legs of your infection control stool really are hand hygiene, cleaning and disinfection, and the use of barriers. Because this presentation is focused on barriers, enhanced barrier precautions, I'm not going to go into hand hygiene and cleaning and disinfecting. We all know how core and critical that is to our basic infection prevention programs. So we're going to dive into the use of barriers, using barriers, and we'll do one more knowledge test here. So the question is, enhanced barrier precautions requires which of the following? Number one, a gown and gloves for all entries and all activities in the resident room. Number two, the use of a gown and gloves when feeding the resident in a common dining area. Number three, placement of a stop sign at the entry to the resident room. Or number four, gown and gloves for all high contact resident interactions, regardless of where they occur in the building. So drop your answer either in the chat or respond to the poll, and then I will hand the poll over to Mary.
All right, looks like we have about 23 responses right now. And it looks like we have a high majority saying gown and gloves for all high contact resident interactions, regardless of where they occur in the building.
Okay, excellent. And that is the best choice. There are a couple of little tricky things there, but yes, number four is the right choice. So thank you, everyone. You're doing great. Okay, so I want to start and talk about standard precautions. So standard precautions has been with us in healthcare for since the 1980s, late 80s. And it's a set of infection prevention practices used for all patients, all residents, all the time, whenever there is a risk of exposure to viruses in blood, body fluids, secretions, non-intact skin, or other potentially infectious material. And that's regardless of what's known about that individual's infection status. One of my little mantras that I always use is if it's warm, wet, and not yours, you wear gloves and other protective equipment to protect yourself from exposure. So that's standard precautions. And then, of course, hand hygiene and respiratory etiquette. So now we'll talk about contact precautions. And contact precautions are used with any individual who's infected with any MDRO, including high priority multi-drug-resistant organisms. Also used when there's acute diarrhea, draining wounds, secretions or excretions that can't be contained. And then sometimes we would recommend the use of contact precautions in situations where we believe or have identified ongoing transmission. So we have a breakdown of infection prevention practices. And then other conditions where contact precautions are indicated would be the diarrheal illnesses like C. diff and norovirus, but also scabies. For considerations with room placement for contact precautions, when we have someone with an active infection with our CPOs or Candida auris, and I have a couple of presentations on YouTube for these two organisms, if you haven't already, organism types, if you haven't already had a chance to view that, I'll include a link in the follow-up email. But those individuals should have a private room and a private bathroom for the duration of their infection. So they should be on contact precautions in a private room. However, roommates or residents who are infected with the same organism or organisms can be placed in shared rooms. So if you have someone who has a CPO and MRSA, you can room them with another patient with CPO and MRSA. So that's really what you want to be thinking about with room placement and is related to contact precautions. So now we're going to focus in on enhanced barrier precautions, which is a system for enhancing standard and transmission-based precautions. An enhanced barrier precaution serves to avoid prolonged isolation and restriction from community activities for our residents. They're not confined to their room, It provides social connection and stimulation and does not require a private room usually. But we do encourage you to do a risk assessment before assigning them to a room. Also, enhanced barrier precautions is not appropriate for residents with an acute infectious diarrhea such as C. diff or norovirus. Before you transition a resident from contact precautions to enhanced barrier precautions, it's important for you to do an assessment, a risk assessment, to determine whether or not that resident who's now no longer infected but colonized has other risks for spread. And the goal for doing that is to identify what those risks for spread are to your other residents in your community, and then what do you need to do in order to mitigate that risk wherever possible. So I'll give you some a quick run through of some resident-specific risk factors to think about. But this is something I would love to have an opportunity to have more dialogue with you folks in the future. But risk factors for transmission would include fecal or urinary incontinence, or residents who have toileting challenges, poor personal hygiene, cognitive impairment and behaviors that can cause significant environmental contamination, such as, fecal smearing in someone who's in memory care, or wandering and accessing other resident rooms or critical spaces. So those are some of those key risk factors to really be thinking about as you change from contact to enhanced barrier precautions. I want to mention, make a note about signs. If you're not using the CDC signs, ensure that your signs do include specific actions to be taken for contact with that resident. And you can see here the CDC sign says hand hygiene, glove use, and gown use. So it calls it out visually. And also you want to make sure that the sign you're using preserves and respects the resident's privacy and dignity. You don't want to use signs that have generic directions, tell the reader to go speak to the nurse, just say stop, or have any information about the resident's diagnosis or any HIPAA protected information. So have a review of your signs and make sure that they're in alignment with these considerations. So indications for enhanced barrier precautions are used with a resident who has an MDRO during all high contact activities, any invasive device, having an open wound, having diarrhea, or where secretions or excretions cannot be contained. So some examples of high contact resident care activities include dressing, showering and bathing, transferring, providing hygiene, shaving hair, teeth care, changing linens, changing briefs, and assisting with toileting. And sometimes, depending on what's happening, they may be indicated in physical and occupational therapy activities. Where these barriers really are most likely to be used are where that high contact activity is occurring. So in the resident room and in shower and bathing spaces. But also keep an eye out for other activities that might be occurring where barriers are indicated, such as unexpected, longer direct care or contact occurring in spaces outside of the resident room or showering and bathing areas. Enhanced barrier precautions should be used for all indwelling devices. So whenever you're accessing or handling a device that enters the body through the skin or body orifice, so central venous catheters, indwelling urinary catheters, nephrostomy tubes, feeding tubes, and tracheostomies. I would also argue that if you have a resident with a trach, that you consider using enhanced barrier precautions as well. And then the third kind of box for enhanced barrier precautions is residents with wounds, and that would include pressure ulcers, diabetic foot or leg ulcers, unhealed surgical wounds, venous stasis ulcers, or any draining wound. Okay, so another quick knowledge test. So Mary B has been a resident of an assisted living facility for 3 years. She does not have a history of MDRO or any invasive devices. Mary recently had a fall resulting in a skin tear on her left lower leg that is covered with a transparent dressing. Precautions for Mary should include 1, no precautions are required. 2, standard precautions when providing wound care. 3, enhanced barrier precautions should be used until the wound is closed or healed. And 4, contact precautions until the wound is healed. So I'll turn it over to Mary to monitor the responses, but please put your response in the chat or use the poll.
All right, so it looks like we have 25 responses right now. 73% of those responses are saying standard precautions when providing wound care, and then 26%, 29% now are saying enhanced barrier precautions should be used until the wound is healed.
Okay, interesting. So the right answer is standard precautions, but I can understand why some might say enhanced barrier because you really don't know the scope of that skin tear. So we can talk a little bit more about that maybe in the question and answer section and circle back. Okay, so room placement for enhanced barrier precautions placements. Resident infected with the same organism can be placed in a shared room. And again, this is colonized. And a consideration to think about is if you have a number of enhanced barrier precautions in your facility, sometimes consider having them cohorted together in one area of the building or one wing might be helpful, especially in PPE supply and that sort of thing. Another special consideration for Candida auris. Residents with Candida auris should remain on contact precautions. Do not take unfortunately, again, we don't have many, knock on wood, in Oregon, but if you do have one, please consult with your OHA regional IP, and for you folks, it would be me, before placing a resident on enhanced barrier precautions, because we want to make sure we're doing a good risk assessment before changing them over. Considerations for cohorting colonized patient without an active infection or open wound. Consider placing them with low risk patients, and those will consider residents with a history of the same organism or those who don't have immune compromise or invasive devices, wounds, an active infection, and who have minimal cognitive or behavioral impairment. And then just some consideration for when you do cohort enhanced barrier precaution residents, try to maintain a 3-foot separation between the beds, use privacy curtains. Again, thinking about pig pen and the amount of contaminant that can be produced or shedding, you might want to consider placing a portable HEPA unit between beds to reduce surface contaminant settling. Increase your frequency of high-touch surface disinfection with your list P germicides. You always change PPE when moving between residents in the same room, and always hand hygiene between residents. Now, when to stop using enhanced barrier precautions. Residents with MDRO colonization should remain on EBP for the duration of the time they are in your building. If you transfer them to another long-term care facility, you should transfer them on EBP because they're going to continue to have that MDRO colonization. Residents without a history of MDRO who have wounds or devices should remain on EBP until the device is removed or the wound is healed. Keep in mind, though, that residents may need to go back to contact precautions if there's a change in health conditions, such as worsening of a wound again, that kind of, or diarrhea or that kind of thing.
I didn't mean to interrupt you.
No, I know. And then I'm just going to do a quick precautions summary. So in summary, standard precautions we use for all residents all the time when coming into contact with blood, body fluid, non-intact skin, mucous membranes, or contaminated surface. So if it's warm, wet, not yours, you wear gloves and other PPE. as indicated by the task you're performing. Then the next step up is we have that enhanced barrier precautions, which we use for residents who are colonized with an MDRO or who have wounds, indwelling devices. I didn't put diarrheal illness here. Oh, that should be there, sorry. And then during high contact activities. Oops. Sorry. And then last on top, we have contact precautions, and we use that for all residents infected with an MDRO, having acute diarrhea, draining wounds, or secretions or excretions that cannot be contained. So now what we'll do is we'll take questions, and there is a satisfaction survey that I would welcome, please ask you to complete. It really is helpful for me in putting these presentations together in the future to know how it landed and if there's anything that I could do better. And then while we have that up, let's open it up for questions. Mary, if there were any dropped in the chat. And don't be shy. Oh, I'll turn off the recording. Okay, recording is